Evening, everyone. It's good to see you all here again, and welcome to the monthly webinar of the Center for Innovation and Precision Eye Health under the School of Medicine of National University of Singapore. So once again, very welcome to you all. Let me introduce myself first. I'm Cheung. I'm an assistant professor at the Ophthalmology Department at NUS Medicine. I'm also the Population Data Science Co-Lead, as well as the Optometry Education Program Director for this center. And today, it is my great honor to have our guest speaker, my dear friend and close collaborator, and in fact, my mentor as well, Associate Professor Carol Cheung, with us today. And she'll be giving us a talk on AI, retinal imaging, and Alzheimer's disease. And perhaps I give a little bit of an introduction on Professor Carol Cheung first. So Professor Carol Cheung is currently based in Chinese University of Hong Kong, the Department of Ophthalmology and Visual Sciences. And today she actually has at least 300 papers. I didn't check because I lost count. She's so established and fundamentally she is well known for her work on retinal imaging, OCT imaging, and at least for the past 5-6 years, she has been going deep into deep learning and coupling deep learning and retinal imaging together. And her representative work include using retinal imaging AI for diabetic retinopathy related screening, as well as glaucoma, diabetic macular edema, and now Alzheimer's disease as well, along with other systemic outcomes. So it is our great pleasure today to have Professor Carol Cheung with us today. And after the talk, we will also have Assistant Professor Raymond Naja to join us for the panel discussion. So without further ado, I shall pass the mic over to Professor Carol Cheung. And just to mention, it is our great honor and very fortunate to have Professor Cheung today. And she's actually not feeling too great today, a little bit under the weather, but she didn't want to disappoint us and she's still here with us, so greatly appreciate that. So Professor Cheung, over to you. Thank you.
Thank you, Cheung, for your kind introduction. It's actually my great honor to share my recent research in this webinar. I really miss Singapore so much. I work with you, Cheung, and Raymond. I haven't really worked with him during my time in Singapore. Professor Tam Wong, Professor Cheung Cheung, and etc. So I really miss everyone in Singapore, and it's my thank you so much for the kind introduction, and it's my great honor to speak here. So today my talk is using deep learning for detection of Alzheimer's disease based on retinal images. So I would like to talk about some of the previous work before we go to using why we are using AI to apply on this topic. So what are the problems? So the world population is aging. It is estimated 1 in 10 has dementia among age 70 years or above, and 1 in 3 has dementia among age 85 or above. Alzheimer's disease, AD, is the most common subtype of dementia and is an increasingly major medical problem with significant social and economic health burden globally. AD is associated with pathological changes in the brain that result from neurodegeneration and vascular disease processes. Current new therapeutic efforts focus on early AD treatment. In this recent new therapeutic treatment is a breakthrough in the field of Alzheimer's disease. But this only focuses on early Alzheimer's disease. The diagnosis of Alzheimer's disease is complex and typically involve expensive and sometimes invasive tests not commonly available beyond highly specialized clinical setting. For example, PET imaging or using lumbar puncture. There is a clear need to develop simple methods to identify asymptomatic individuals who are more likely to have AD in the community. High-risk individuals could then benefit from subsequent more intensive and specific examination for early diagnosis and timely treatment. Particularly new AD drugs are approved recently. The retina, a neurosensory layer tissue lining the back of the eye, provides non-invasive visualization of nervous system and human microcirculation. The retina is now considered a platform to study disorder in the central nervous system since it is an accessible extension of the brain in terms of embryology, anatomy, and physiology. Given the transparent nature of our cornea, lens, and features, the structure of our eyes can be imaged easily using imaging technologies. Today, we are going to focus on retinal imaging, which are retinal fundus photograph and retinal optical coherence tomography, OCT. Retinal fundus photography is the commonest method for imaging the retina, which is the back part of the eye. Top view of the retinal structure, including optic disc, nerve fiber layer, and retinal vessels, can be captured easily. Different eye diseases can be imaged using retinal fundus photographs, such as diabetic retinopathy, diabetic macular edema, glaucoma, and age-related macular degeneration. In addition to retinal fundus photography, OCT is another widely used imaging device in the field of ophthalmology to image cross-sectional view of retina. So this is a cross-sectional image of macula captured by OCT. Most of the retinal layers can be clearly identified by using OCT easily. OCT is non-contact and non-invasive optical technology that imaging the retina and optic nerve head in three-dimensional view with very high speed. For example, for a 3D scan around the optic nerve head, it only takes 2 seconds for obtaining 3D volumetric data with a scan area of 6 mm by 6 mm. In tertiary care, OCT is widely used to identify and manage eye diseases in eye clinics. For example, glaucoma, which is characterized by thinning of retinal nerve fiber layer thickness and optic disc cupping. Measurement and assessment of retinal nerve fiber layer thickness by OCT is now commonly used to detect glaucomatous optic neuropathy for diagnosis and management of glaucoma. OCT is also used for diagnosis of different retinal diseases at macular region, such as diabetic macular edema. Measurement of retinal macular thickness and assessment of cross-sectional macular morphology can be easily obtained by using OCT. We can now using these retinal imaging techniques to document the changes in the retinal neuronal structure and retinal vasculature easily. These retinal imaging tools offer unique information on the status of the cerebral neuronal structure and microvasculature that is distinct from brain imaging measures. In this presentation, I'm going to give more details how we use retinal imaging to study Alzheimer's disease and the current literature. First, the retina is composed of layers of specialized neurons that are interconnected through synapses. Visual information is passed along the axons of retinal ganglion cells, which are myelinated as they leave the eyes, forming the optic nerve and providing connection between the eye and the central nervous system. Particularly, retinal neuronal structure can be easily captured by OCT. Furthermore, the retinal blood vessel shares similar embryological origin, anatomical features, physiological properties, and regulatory mechanism with the several small vessels in the brain. Similarly, retinal vasculature can be easily captured by ocular imaging devices, including retinal photography and a more recent developed technique called OCT angiography. Therefore, retina is unique and accessible window to study brain neuronal and microvasculature pathology in vivo. So now we know the background and concept. What are the previous studies shown? Since 1989, I think this paper is 1986. Optic nerve provides these histological studies have clearly demonstrated the loss of retinal ganglion cell and optic nerve axons in Alzheimer's disease. Hinton's first reported optic neurodegeneration in AD in a postmortem study in 1986. OCT has made remarkable advances in assessing retinal ganglion cell axons by quantifying pupillary retinal nerve fiber thickness, particularly in in the last 2 decades. So this is the first generation of OCT, time domain OCT, which measure retinal nerve fiber layer thickness around the optic nerve head. Using this time domain OCT, which is the first generation OCT, few small clinic-based studies have consistently shown that retinal nerve fiber layer thinning is found in patients with Alzheimer's disease compared with normal controls, suggesting OCT may be useful to assess neuronal loss in Alzheimer's disease. And more detailed and precise quantitative assessment of retinal layers can now be performed using the second generation and third generation OCT. So particularly, namely spectral domain OCT and swept source OCT. And this newer degeneration OCT enable visualization and measurements of ganglion cell layer and inner plastiform layer additionally in the macular region, which contain both the cell bodies and also the cell dendrites in addition to retinal ganglion cell axons. So in spectral domain OCT, measurement of we call macular ganglion cell inner plastiform layer is available to assess optic neuropathy at the macular region, in addition to peripapillary retinal nerve fiber layer axonal measurements. Numerous studies have investigated the association between OCT measures and AD dementia. In a meta-analysis, we further confirmed that Alzheimer's disease patients have significant thinner average ganglion cell inner plastiform layer thickness and macular region, in addition to well-established retinal nerve fiber layer thinning in Alzheimer's disease. In addition, we also examined the association of ganglion cell inner plastiform layer and retinal nerve fiber layer thickness with global and regional cerebral atrophy on MRI. We found that decreased ganglion cell inner plastiform layer is associated with gray matter loss in the occipital lobe and also temporal lobe, providing positive and potential insights for using OCT to assess neurodegeneration in the brain. Importantly, in a paper analyzing UK biobank data, it is shown that retinal nerve fiber layer thinning is not only associated with concurrent poorer cognitive function, but also associated with future cognitive decline. In the lowest two quintiles of baseline retinal nerve fiber layer distribution. And it also shows that increase the number of cognitive tests with worse scores on follow-up testing is significantly associated with retinal nerve fiber layer thinning, demonstrating that retinal nerve fiber layer thinning is associated with future cognitive decline. Furthermore, in the prospective population-based Rotterdam study, it is also shown that thinner retinal nerve fiber layer at baseline is associated with increased risk of developing dementia, including Alzheimer's disease, suggesting that OCT may serve as a preclinical marker of dementia. How about literature on retinal vasculature? Retinal fundus photography is the classic imaging technique to capture changes in the retinal vasculature. Qualitative retinal vascular changes, including retinopathy size, which is like retinal hemorrhage, cotton wool spot, focal artery narrowing, artery vein nicking, and also ossification of arterial wall. It is noteworthy that these retinal signs are, however, relatively late indicators of target organ damage in the eye, and probably reflect are found stages of structural vascular damage, including breakdown of the blood retinal barrier. So over the last 2 to 3 decades, image processing techniques have provided the opportunity to quantify retinal vascular changes from retinal photographs. Measurements of retinal vascular caliber or diameter using computer software has been proposed for documentation of generalized retinal vessel narrowing or vessel widening, in particular in large population-based studies. Different studies demonstrate that retinal vascular changes, including classic retinal size and quantitative retinal vascular caliber, are associated with cognitive dysfunction and dementia. For example, In the ERIC study, the group has examined the relations of retinal vascular changes with cognitive function in middle-aged persons free of stroke in US. Persons with vascular changes, including microaneurysm, retinal hemorrhage, and soft exudates, are more likely to have poorer cognitive function. In the same ERIC study over 40 years of follow-up, the group has further found that the persons with retinopathy and focal artery narrowing have a significant decline in cognitive function score, demonstrating that retinal vasculature changes contribute to impaired cognitive performance. In the Rotterdam study, the group correlates retinopathy with prevalent dementia and incident dementia. They found that persons with presence of retinopathy are more likely to have prevalent dementia and prevalent Alzheimer's disease. This also demonstrating that there's a evidence using between retinal changes and risk of and also as with dementia and Alzheimer's disease. Human circulation is a branching system that follows a physiological principle of optimum design. There are newer global geometrical and branching parameters, including bifurcation, fractal dimension, and tortuosity, have also defined over last decade to capture different aspects that how optimal and how efficient of the microcirculation are assessed from retinal vasculature. My previous colleagues from Singapore and I examined the relationship of the retinal branching parameters with cognitive function in a population-based study in Singapore. So we found that decreased fractal dimension, indicating a sparse retinal vasculature, is associated with poor cognitive performance. And these are the two examples. So these are smaller fractal dimension, and this is a higher value or not optimum value of fractal dimension. We also conduct a case control study and observe that patients with Alzheimer's disease have narrow retinal venules and a sparse and more tortuous retinal vessels compared with matched non-demented controls. In another study, we correlate quantitative retinal vascular parameters with cerebrovascular diseases. We further demonstrating that retinal vascular changes, including narrower, sparse, and more tortuous vessels, have been linked to cerebral microbleeds, which are preclinical MRI imaging markers of cognitive decline in Alzheimer's disease. In addition, changes at the capillary level may also be studied for their relationship to Alzheimer's disease dementia. Recent reports have identified changes in the retinal capillary network using OCT angiography in AD dementia and preclinical AD. It is shown that patients with AD Alzheimer's disease have lower capillary network density and have larger fovea avascular shown area. In addition, changes at the capillary level may also be studied for their relationship to Alzheimer's disease dementia. Recent reports have identified changes in the other new image technologies such as hyperspectral imaging and also retinal optometry. So these studies provide evidence to support the concept that changes in retinal neuronal structure as well as in retinal vasculature may reflect similar pathophysiological processes in the cerebral circulation and neurons in AD. And AD has a unique retinal fingerprint that can be detected by retinal imaging. But is retinal imaging a viable biomarker for AD? Before we answer these questions, let's refresh the definition of a biomarker. A biomarker is defined as an objective substance, characteristics, or other parameters of a biological process that enables the assessment of a disease risk or prognosis and provides guidance for diagnosis or monitoring of treatment. Biomarkers may aid in risk profiling to identify those at greater risk, detection of pathology at the earliest possible stage, and by providing endpoints for trials that identify benefits earlier in the natural history of the disease, thus accelerating the development of new treatments. For example, measures of amyloid beta and tau pathology using PET or CSF are biomarkers of AD. However, current measures of retinal imaging are not specific to Alzheimer's disease. Alteration in retinal vasculature and retinal neuronal structure may be associated with aging and other ocular, neurological, and systemic diseases. Second, strengths of the association between retinal imaging parameters with AD are relatively modest. It is likely that some retinal features are not fully represented by currently defined parameters. Also, there are no good ways to incorporate features from both retinal neuronal structure and retinal vasculature. Retinal imaging has not yet to meet the requirements to be considered a biomarker. Regarding no current measures are specific to AD, AI has great potential to address these gaps. In the last few years, deep learning technology, which under the umbrella of AI is developed rapidly and a major area of future research in the analysis of medical images to transform healthcare, focusing on image classification and pattern recognition. Indeed, Raymond and Cheung are also experts in AI in ophthalmology. So the concept behind deep learning is that deep learning permits software algorithms to be trained through multi-layer neural networks, which is a large mathematical functions with millions of parameters, called convolutional neural network, CNN. CNN is inspired by the ability of brains to learn complicated patterns in data by changing the strengths of synaptic connection between the neurons. The major merit of using deep learning is that the features are automatically learned by neural network in the feature extraction stage. In ophthalmology, studies are already demonstrating that deep learning algorithm can be trained using large data sets of retinal photographs and OCT to identify eye diseases such as diabetic retinopathy, diabetic macular edema, and glaucoma, and the performance is at least as good as clinician and professional human graders. More recently, several studies on deep learning predicted systemic conditions from retinal photographs have also been published, including cardiovascular risk factors, serum creatinine, kidney disease, diabetes, and cardiovascular disease modality, demonstrating that deep learning can be applied to make novel predictions from retinal images. So recently, we have developed a deep learning convolutional neural network that aims to provide a simple retinal imaging-based screening tool to identify individuals at risk for AD. I would like to take this chance to thank Cheung for his help and support on this work indeed. In this study, we used retinal photographs from 526 subjects with AD dementia and 2,999 subjects with no dementia from 6 datasets from Hong Kong, Singapore, and UK for training and validating our deep learning algorithms. In addition, 3 external datasets with amyloid PET imaging and 2 testing datasets with clinical data labeled from Hong Kong, Singapore, and US for testing our algorithms externally. So we designed the deep learning model to integrate AD-related retinal features from multiple retinal photographs from both right eye and left eye, and from both optic disc center and macular center fields, and use novel deep learning methods to integrate information from each study subject and predict no dementia and AD dementia. So this table shows the performance of our deep learning-based model in the internal validation and also testing data sets. For discrimination between AD dementia and no dementia, both models achieve accuracy of 83.6% and AURC of 0.93 in internal validation. In the testing data set, the model had accuracy of 79.6, 89.3, 85, 92.1, and 91.7 in the 5 independent datasets, respectively. In the 3 testing datasets with amyloid amyloid beta status from PET, the model was able to discriminate between amyloid beta positive and amyloid beta negative subjects with accuracy of at least 80%. Our work demonstrates that deep learning has great potential to discriminate AD-related retinal changes from cognitively normal controls. To increase the applicability, we intentionally included retinal photographs with concomitant eye disease in the training datasets because age-associated eye conditions are common in people older than 60 years. Meanwhile, excluding eyes with this condition might also introduce selection bias. In the subgroup analysis, our algorithm retained a robust ability to differentiate between people who had and did not have AD even in the presence of eye disease and also diabetes. So furthermore, patients with type 2 diabetes are at high risk of cognitive impairment. Our deep learning algorithm performed well without significant interference from these two potential confounding factors. We also developed a unilateral model for single eye analysis because individuals may have an ungradable retinal photographs from one eye due to, for example, severe cataract. The unilateral model fills the information from both optic disc center retinal photograph and macular retinal photograph image in only one eye for the prediction, AD dementia prediction. So we found that the performance of the unilateral model in the testing was not as good as the bilateral model generally, but it is still acceptable. A unilateral model is essential for community screening of AD because it is not uncommon that retinal photograph of one eye is not being accessible due to media opacity. Currently, we are developing a secure IT infrastructure for real-world implementation and plan to conduct a prospective pilot study to test our AI system in Hong Kong to move from concept to implementation. The outcome from this study will allow us to understand the factors and processes that influence implementation of AI devices and ensure success through developing a sustainable system. We believe that classification of AD based on retinal imaging could leverage existing community eye care infrastructure, for example, of optometry networks that enable opportunistic AD screening during routine examination and screening for common eye diseases. For example, deep learning algorithms are already in use for community DR screening in Singapore. High-risk individuals identified by this DL model could then benefit by selective referral for more intensive and specific examination, for example, PET imaging, plasma assays for amyloid beta and tau, and more specialized clinic for definitive AD diagnosis, possibly at early stage for preventive measures. As the calibers of the retinal arteries and venules have been proposed to be surrogate measures of systemic microvascular health, we have developed and tested a deep learning system to specifically measure retinal vessel caliber from retinal photographs using a large and diverse multi-center, multi-ethnic, multi-country data sets of retinal images. We find that narrower retinal arterial caliber and granular venular caliber at baseline were associated with incidence cardiovascular disease. This AI tool allows us to study the human microcirculation via the retinal vessels in an easier manner. We also applied this AI tool in a cohort recruited from Memory Clinic in Singapore. So a total of 491 participants were included in this study, of whom 254 developed cognitive decline over 5 years. In the multivariable cause regression models, narrower retinal arterial caliber and wider retinal venular caliber were associated with increased risks of cognitive decline, supporting the use of retinal imaging and retinal vessels assessment, a marker for the cerebral microvasculature, as a non-invasive potential tool to screen and stratify individuals who may be susceptible to cognitive decline. In addition to image-based AI, other AI techniques are explored in medicine. For example, we have proposed to use deep reinforcement learning, a learning strategy that constructs an optimal policy through trial and error to solve decision-making problems. Another example is large language models, especially ChatGPT, developed by OpenAI, have attracted attention to various fields worldwide. Indeed, Cheung is, again, he is an expert in this field. I'm learning a lot from him using LLM in ophthalmology. So a few reports have already demonstrated that the capability of ChatGPT for answering practice questions for ophthalmology, broad certification examination, and diagnosis of eye diseases. And different editorials are also discussing benefits, limits, and risks of ChatGPT as an AI chatbot for medicine, and what AI chatbots mean for editors, authors, and readers for peer-reviewed ophthalmic literature. Recently, Geoffrey Hinton, godfather of AI, quit Google, warning of the dangers of AI. And the CEO of OpenAI's call for laws for mitigate risk of increasing power AI. So how should we use AI, and what risks the technologies poses to patients and clinicians? I think before we continue our journey of using AI in medicine, communication and understanding each other is important. Lots of time, people is too focused on their own perspectives. Communication and understanding of each other are essentially important in order to deploy AI strategically in our healthcare system to benefit patients and stakeholders. So in summary, recent studies have demonstrated a link between retinal measures with dementia and Alzheimer's disease. Retinal imaging may provide a complementary approach to study the pathophysiology of AD. AI deep learning has potential to automatically interpret retinal images for AD detection. Additional studies are required to test and translate retinal imaging to screen for AD. So keep learning and being innovative to benefit our patients and improve our healthcare system. So last but not least, I would like to acknowledge my colleagues in Hong Kong, my mentor, Professor Tan Wong, from now in Tsinghua, Professor Christopher Chen, Professor Chen Yu Chen, Yu Cheung, Dr. Simon from Singapore, and my other collaborators in UK. Thank you so much for your kind attention.
Oh, that is wonderful. I think simply mind-blowing. Decades of work, and I'm not being exaggerated, really decades of work. And if you guys can see from Professor Cheung's publication, all this started in year 2012, 2013 until now. So back then, no deep learning yet, but through imaging measurements on the images already indicative that those retinal imaging parameters can predict Alzheimer's disease. And then halfway through, with the introduction of deep learning, she further elevated the work to the next level. So really, body of work, body of evidence, many congratulations to Professor Cheung, and very insightful sharing. And I think all of us really had a good treat tonight, just in a short 40 minutes or less than 40 minutes, but essentially it's a summary of past 10 years of your work. So thanks very much again, very insightful sharing. So next, we shall proceed to our panel discussion. Before we commence, I would like to first introduce Assistant Professor Raymond Naja, who is also an Assistant Professor at Ophthalmology Department at US Medicine. He's also the Deputy Research Director at our department, and we are very pleased to have him to join us for this evening's panel. And just to remind all our audiences, if you have any burning questions, please feel free to type in the Q&A box. You see at the bottom of your screen, there's a Q&A feature. Feel free to type in your questions. And I can see that we already have a couple of questions coming in. Yeah, maybe without further ado, I think we can start with the first one. So the first question is obviously in the talk there are a few modalities being mentioned. So Professor Cheung, in your opinion, which modality is better, retinal photo or OCT, or should we use both? Uh, Carol, any comments on this?
Yeah, thank you for the questions. It is not easily to say which one is better because indeed retinal photograph captures something for example, capture retinal vessels, particular arterioles and venules that that OCT cannot capture. And retinal photograph can capture retinal vascular pathology, for example, retinal hemorrhage or cotton wool spot. So I think this is different to retinal image modalities, but OCT can capture more detailed retinal, particular neuronal and axonal layers that retinal photographs cannot capture. Although retinal photographs can capture optic disc and the top view of the optic nerve fiber layers. So I think ideally, from my point of view, both modalities should be used at the same time because one of the hypotheses is that if we combine two devices together, given that a retinal photograph can give more information on the retinal microvasculature, and OCT can give supplement information for neurodegeneration. The outcome for predicting, for example, Alzheimer disease will be higher. But of course, we don't have this kind of study, but I won't say it is better. But obviously, OCT is more expensive than retinal camera because due to the designs of the devices. I think the light source is expensive. Some even OCT, for example, spectralis, they have an additional laser to track the eye for eye movement. So it's also increased the cost. So I think in science, or to answer more scientific question, I would say that I would like to use both to see which one is better. But I think if we go back to we want to use this for AD screening, I think cost and also the feasibility is also importantly to consider.
Thank you, Carol. Raymond, you work on portable devices as well, particularly for screening. Do you have any perspectives on this?
Yes, thanks, Cheung. Carol, thanks again. Phenomenal talk as always. Just a quick comment on this. So it's true that I agree with your answer. I'm just wondering, is there a way we can combine your deep learning approach to other metrics for assessing Alzheimer's or risk for Alzheimer's? Questionnaires, eye movements, pupil response. Could it be a multimodal approach for this to improve the specificity of detecting or a risk of AD through the eye, or maybe through a combination, of cognitive assessment plus deep learning? What are your thoughts on this?
Sorry, you say combining? Can you say?
I apologize. So yes, I'm just asking, is there a way to have a multimodal approach, not necessarily using OCT or fundus, but using other metrics to evaluate cognitive impairment in patients, like questionnaires, like pupil size? Is there a way to combine these to improve the specificity of our measurements?
Yeah, I believe it will be help if for example, questionnaire is easily to or it is available for screening already. But of course, questionnaire is not specific to which type of or causes of the dementia or cognitive decline. But the the beauties of the retinal imaging, it can be we can from the model that I share with you, it is specific for Alzheimer's disease, which is the major cause of the dementia. So I think but on top of that, if we can have more research, for example, what you mentioned, the pupil size, which can detect the the function of the eye or the response of that, I think it will be doable. But again, measuring the response of the pupil dilation, I'm not expert. You are the expert in this area. So do you think it is feasible, or it is easily done, or from participants? How long is the examination take for collecting the data on the pupillary response?
Sure. I hope you can hear me better now. So ideally, it could be very quick to assess. It would take around 1 minute per eye with the specific light stimulation paradigm. And I'm just wondering if we can make the detection of or the prediction of Alzheimer's disease better by combining these two modalities, like one functional and the other is structural, right? And then we can evaluate whether it is or it is not better than a single model on its own. It may not improve, but it may also improve the detection. There are parasympathetic and autonomic issues in Alzheimer's disease that could be reflected on the pupil as well. So just something we should work on, and I'm happy to work with you.
Yeah, I think it's a good research if we can do it, together, yes.
Okay, excellent. Looks like there are a few more questions. I'll try to tackle a few more so we can keep things going. So there's a question on whether specifically the deep learning work that you just showed, can it also detect mild forms of Alzheimer's disease? Was that shown in the paper?
This is a very good question. So indeed, in the paper, we trained AD dementia, which is we didn't test on patients with mild cognitive impairment yet. So this is our next step that we hope to capture to catch the early AD, that the patients, they have mild symptoms but did not develop to dementia stage yet. So but we have a subset of testing data sets showing that those have amyloid positive, and we can differentiate by using the PET data. So in those testing data sets, some subjects indeed they don't have the dementia, but they already have amyloid positive. So, but again, I think we need another proper study to answer these questions.
So there's a follow-up question on that, also pertaining to the Lancet Digital Health paper. The last few slides where you show the subgroup analysis, it shows that amongst the individuals with eye diseases, the accuracy rate is even higher. So what is the possible reason behind this?
Because the AI is black box, so we don't know exactly. But I think previous studies have already demonstrated that particular AMD and glaucoma are associated with Alzheimer's disease. We don't know the causal relationship because currently the findings is still inconsistent. We know that patients with Alzheimer's disease, they tend to have eye diseases, and on the other hand, people have eye diseases. They also have higher chance to have Alzheimer's disease. So we believe that there are similar pathophysiology between this eye disease and Alzheimer's disease. I think we need a proper study design to answer this question.
Yes, that's correct. I totally agree with Carol. So I think that particular analysis just shows that the AI is not doing random guessing. It is indeed consistent with what we know previously amongst individuals with eye diseases. Indeed, the prominent effect of association with Alzheimer's disease. And there's another question. So all the retinal imaging marker that we have shown, it may be related to cognitive decline, neurodegeneration, but may not be specific to AD. And how do we reconcile this? So in the interest of time, I'll just quickly take this on behalf of Dr. Carol. Essentially, I think that the use case here, which Professor Cheung have shown, it's more for screening at this juncture, less for differential diagnosis. It's more of picking out something abnormal at a first cut and then decide what to do next, whether to triage, to refer, for example. So moving on, there's another question, probably from our optometrist colleagues. Say, for example, if we were to use this AI retina imaging in a community optometry setting, but once we get the result from this AI report, it may be difficult for the optometrist to explain to the patient. So what are your thoughts on this?
This is also a very good question. We keep discussing with different stakeholders in Hong Kong. Maybe I hope that I can come to Singapore to further discuss with you guys. And I really want to know what are the different stakeholders, what are they think, what are their plan, what do they need, and then to deploy this strategically that I mentioned. So I think currently we mainly in Hong Kong, I'm working with a neurologist, which is with Professor Vincent Mock on that. Of course, they, based on what data we shown, they are confident. They say that those had higher probability to have AD. They will recommend them for a PET scan or doing a recent biomarker test for beta amyloid or tau. So I think for our optometrist colleagues, I think they may not be able to do this, and even our ophthalmology colleagues. So if they have this, if they have retinal camera, they have this. So what they can do? So I think we need more discussion and like consortium to group everyone together and hope that everyone we can brainstorm that what can we do using again, hope that the technology can help in this field. I'm sorry that I don't have a good answer for this question, but I'm more than open to listen to the opinions from our optometrist colleagues.
I think it's an excellent question, and it probably goes back to what Professor Carol mentioned during her talk, the deployment and the considerations when it comes to deployment and implementation. And I think there's a key phrase that she mentioned during her talk, opportunistic screening, meaning the site already has a retina camera. You put in this AI, which can perform this screening. Optometry practice being one, diabetic retinopathy screening sites being another one as well. But the deployment implementation at the optometry practice versus DR screening site can be quite different as well. Say, for example, DR screening, these are diabetic patients going for their follow-ups. They go maybe their half-yearly follow-up and they see their GPs there. The consideration of deployment there will be a little bit different. Once, let's say, the AI Alzheimer's disease flag out something suspicious, there's already a doctor there to decide what to do next. Versus optometry practice, and I totally understand where this question comes from. Let's say the retina AI report comes up and flags something very suspicious. Should the optometrist refer directly to the neurologist? You go straight up to the tertiary, but is it like being overly sensitive? Are we causing a lot more false positive? Are we causing over alarming to the patients as well? So these are genuine concerns as well, which is why I think the criteria and how to refer really depends on settings as well. Raymond, did you have any thoughts on this?
Yes, definitely. I agree with you, Cheung. I also agree with Carol. Carol, just a quick question. In your fundus cameras, did you have any portable fundus cameras that you tested? Portable cameras?
In this study, no. All are desktop retinal camera.
Got it. And do you think that portable fundus cameras could open up a little bit the screening, the opportunistic screening field to like GPs, to other specialties that don't have like big fundus cameras, would that be an option? I assume you will be testing this in the prospective study. It's great that you have a prospective study on this plan, but do you think that would be also a place to test and
Yes, of
to look
course.
for
Yes.
AD, potential risk of
We
AD?
are looking. We are actually proactively searching for good handheld retinal camera, and also smartphone-based retinal camera to further test the feasibility. But again, I think the implementation, the deployment need to be do it strategically. Need to even with we have this set up for GP. For GP may be easy because they can write referral or etc. But or they but I think we need more brains to think of how we are going to use this. I'm happy that a lot of people are interested in this work, and I hope
Definitely.
to have opportunity to gather more people to have more thoughts, comments, advice that how can we use it more strategically to help patients, to help to healthcare system. Indeed, actually, the caregiver for patients with Alzheimer's disease, they are very burdened to look after patients with dementia. So I think if we can identify patients at earlier stage, and right now there is new drugs that can help to potentially to stop or the progression to cognitive decline. I think that is good for the patients and their whole family, and also for the whole system as well, medical system.
Excellent
Thank
point.
you. So just a quick comment, Cheung, maybe on the false positive. I assume you can adjust the threshold of your algorithm, right, to make it very specific and then avoid a false positive. Is this something you are testing in the prospective study to see where do I put the threshold of my algorithm so that I don't refer too many false positives to the neurologist? Right, that's, I assume, is an option as well in your approach.
Sorry, come again, Raymond. We lost you the last bit. The last line.
Oh, sorry. So I was saying the threshold of the algorithm can be adjusted basically to reduce false positives and have a very high specificity, especially if you're doing opportunistic screening. So I assume this would be very helpful to avoid a high rate of false positives. And that will be the last comment for me. But I assume this is something you're doing as well, Carol, right?
So, Raymond, I just want to comment on this. So I think several things that I'm thinking. First, we are planning for our prospective study in Hong Kong, but in fact, it's not that straightforward. Like to find the vessel from our retrospective analysis to apply in newly cohort, because the setting may be different. So indeed, my team and I, we are working what is the best approach to find a cutoff point of in new cohort, because the data actually that although we have external testing, but still we are just showing AUROC curves. But what is the best cutoff point? As you mentioned, we need more higher sensitivity or high specificity. This also depends on which settings you are going to locate the system. Let's say, for example, to neurologists, they don't want to see false positive cases, so they may need a very they don't want they want a high specificity for us because if you refer to them, they may do PET scan, a lot of expensive tests, etc. So, but if it is in but if it is in like GP primary care, they don't want to miss anyone, but they may set the sensitivity higher, but they may need to face an issue to have higher false positive rates. So I think again this needs more discussion. So not just the settings, we may need to have a better statistical analytical plan for how to find the good cut-off point when we talk about the deployment. So this is not that straightforward. That's what I'm facing right now.
So Carol, at the moment,
do you have any thoughts or advice to us?
Well, I always say advice because I myself I'm facing similar challenges when it comes to implementing in different settings, and even in Singapore context, each setting, let's say each clinic is different, optometric practice is different. So this is a very interesting puzzle to solve. And on this note, actually, I wanted to find out from you currently, your AI and retinal imaging, to process the retinal photo, do you do web-based, meaning the photo goes to the cloud and you do AI analysis, sends back the report, or it's an offline approach?
It's an offline approach still, yeah.
Okay, excellent. Yes. Going back to your question, I think I totally agree with what you and Ray said, and learning from my own failures as well. Probably not that easy to set a cutoff, and I think now embarking more on implementation science work, I realized that it's important to frame the use case, the application of the AI tool with implementation science principles. Say, for example, is it going to be used as sole standalone screening tool, or is it supposed to be used as an assistive adjunctive tool? Say, for example, assistive adjunctive tool, meaning is not meant to screen everybody. It's meant to use in a situation whereby the family member suspected that the patient has some suspicious symptoms or behaviors, and based on simple questionnaire or based on daily behaviors, they suspect that maybe memory on the decline. And instead of going straight to the tertiary setting, maybe just do a retinal imaging first as an assistive adjunctive tool to further confirm their suspicion before deciding whether to refer to tertiary. It can be something like that. Or purely standalone screening tool, meaning it's just part of the elderly screening, the annual health checkup. Whenever they come in standard, they also do a retinal imaging and to screen it. But to do that, there's a high chance that we may be picking out a lot of suspicious cases, and there's a high chance we may be over-referring as well. So there are pros and cons, and from what I learned from my own hard lessons, probably it depends on what setting and what's most beneficial. And my personal view for AD is more as an assistive tool. And I think a lot of times when patients are healthy, they themselves are behaving fine, even if they come for the retinal imaging, and if the AI report shows out something to be suspicious, they won't be convinced that they should be referred, or the family members won't be convinced. But when the family members suspect something, and then this further provides some assistive information, then there's some valuable information there. I think there's one last question, again from your good friend Carol, Victor. So Victor will be keen to find out from you what is the based on your own experience now, and you're trying to translate it to real world use. So in your mind, what is the most important barrier in terms of adopting AI tool and translating it for real world use?
I think the barrier is what are we adjusting the current gaps? Our data is strong enough to addressing the current gaps. So I take this study as an example. So why I think it is quite a hot topic right now, because there's new drugs in Alzheimer's disease. So if we can identify early Alzheimer's disease, then it can be the patients may benefit for this early timely treatment. And this retinal imaging, this algorithm is potentially used as a screening stage, and then maybe second stage. There is also currently using blood tests for screening Alzheimer's disease. So it is more expensive than retinal imaging, but cheaper than PET scan. So that's we actually proposing there's several stages before they do a blood test for a more pathology specific test, because the blood test actually is identify the Alzheimer's disease pathology from the blood itself. So this is also quite a hot field in the field as well. So it can maybe this approach can be easier to allow which patients should be go for a definitive PET scan to identify really have early AD disease. So to me, I think the barrier because I've also worked on other AI field as well. So a lot of people actually challenge me. You are not changing the practice because of several reasons. So I think identify the good questions using the technology and then show the data. It is convincing and to have can change the practice to have the impact. It is essential. So I'm not sure whether I can answer Victor's question, but that's from my experience. Yes.
Oh, excellent. And I totally agree with Carol. And on this note, there's a very good comment that just came in. I wanted to share with everyone here. So firstly, alluding to what Carol said earlier, essentially we're not, with all these AI tools, we're not trying to change clinical practice, but more importantly, we're trying to improve the flow of clinical pathways. And alluding to what Carol said, how do we best decide who should go for the expensive PET scans? Not everybody, of course, the high-risk group, but how can we further enable more precision in terms of performing this triaging and referral? And there's a very good comment that just came in. First is to target on the high-risk group. And our colleague, Dr. Anu, mentioned that some of our polyclinics run memory clinic, and I'm aware of that. I think this is a very good point. So can AI retinal imaging be included in the future as part of the screening panel test, along with all the memory tests and also even looking at the blood markers? Personally, I think it is highly possible, and by doing this, probably it can further help us to better triage and to decide who should indeed go for the expensive PET scans and who should be monitored a little bit more. So again, our approach here to bringing AI, it's not to change clinical practice, but to further optimize our referral flow, our clinical operation. Carol, any further thoughts on this?
No, yeah. Once again, thank you so much for having me in this webinar. I'm so happy to see you, Cheung, and Raymond, and of course I can't see Victor, but I'm very glad that colleagues are here, friends are here too.
Excellent. So once again, please join me in thanking Professor Carol Cheung for the excellent talk, and Assistant Professor Raymond Naja for joining us as panelists for this very exciting and very interesting discussion. So I think today we have almost 400 participants who logged in to listen to this talk, one of the highest actually. So that shows your charm, Carol, and we would like to have you back again, and hopefully next time when you're back, we will hit 500 or 600.
Thank you. Yeah, I look forward to the next one.
So speaking of the next one will be on the 14th of November, which is also a Tuesday. It's always on a Tuesday. It will be we will be having Professor Jerry Allen Manikoff. He's a professor of bioethics, and he will be talking about flexibility of ethical principles and how these ethical principles can empower eye care. And it will be chaired by my colleague, Dr. David Cheung, and that will be next month's webinar, 14th of November. So once again, thank you all for joining us, and I'm well aware of time, and we shall close this session. And thank you, Professor Carol Cheung, once again. Thank you very much.